4, but we'll try to stay within our time frame. And thank you guys for taking your morning to log in to participate with this presentation. So as always, this information is confidential and privileged. Do not distribute or copy it. And by a little additional thing from previous presentations is that by attending this lecture, you understand and agree with this confidentiality statement. So moving on to case 1. Case 1's a 68-year-old female who complained of shortness of breath. PPE usage was maximum and appropriate. Primary survey is that this patient was awake when they arrived. Her airway was open, but she was clearly labored in her respirations. She had no signs of active bleeding. Her skin was documented as normal. And that the vital signs that were obtained were by prior to arrival of the transporting agency, noted to have tachycardia at 140, hypertension at 230/141, a respiratory rate of 30, and a SAT of 93% on Cpap upon the transporting agency's arrival. She's a smaller woman at 60 kilos. Past medical history includes COPD, previous recurrent pneumothoraxes, hypertension, and reflux. And according to the patient's daughter, she abruptly developed shortness of breath. She called a panic alarm that alerted her daughter, who was within the household for this patient, and noted that she was profoundly short of breath, prompting 911 initiation. And because of the severity of the patient's shortness of breath, the information was predominantly obtained from the daughter. They had mentioned that they had a chest tube placed within the last month, and that, again, a history of recurrent pneumothoraxes. So a lot of treatment happened during this encounter, so I apologize, the left is pretty busy, but I also believe that it represents the time frame that's important for us to look at and evaluate. So this is time frame based off of the transporting agency's arrival. So within 2 minutes of arrival, she was started on both albuterol and Atrovent for bronchodilators. Within 15 minutes, an IV is established, and within 6. So what I should mention before the 16-minute interval is that the first on scene had documented and assessed bilateral breath sounds were present, and that they felt that this was more likely in lines of reactive airway disease secondary to her COPD. But after 16 minutes of the transporting agency's arrival, they noted that she was more short of breath and that she had diminished breath sounds on the left side. They took her off the Cpap, placed her on a neb mask, and obtained a 4-lead. Repeat vital signs at this point shows persistent tachycardia. Blood pressure was not obtained, and still tachypnic at the rate of 34 with SATs of 97%. Her end tidal being 47 and her glucose normal. It's a little bit unclear in this documentation, but based off of ER triage, I believe this is when the patient became more somnolent, potentially even unresponsive. So the decision was made to RSI her. 27 minutes into the call of the transporting, she got 120 milligrams of ketamine, using that over etomidate given her reactive airway disease and concern for bronchodilation. Maximization. They bagged her, they gave her 90 milligrams of Succinylcholine, and they attempted at 30 minutes to intubate her using DL. Unfortunately, this attempt was unsuccessful. They felt that she was still pretty, that tone was still present, complicating the attempt to intubate her. So another 90 milligrams of Succinylcholine was given. And at this second time, they were also unable to intubate her using video laryngoscopy. So an iGel was placed. Repeat end tidal CO2 shows that she's retaining during that intubation attempts from 47 to 71. In transports initiated, she was able to be bagged effectively with the iGel. After transport, they attempted to needle decompress her on the left side between the 4th and 5th intercostal space. They documented that it was successful and that her end tidal did decrease after either placing an iGel and or the attempt to decompress her. And then she received 1 dose of 5 milligrams of, it's documented as IM Versed, but after speaking with that particular agency, it was IV Versed because she had an IV. And then she arrived at the hospital at 47 minutes. And the only other addition is that at bedside, she was tripoding. So in review of this case, just the pre-hospital side of things, the importance of good physical exam in reassessment, the initial scene presenting crew documented very thorough physical exam findings to support the use of their decision to support the use of Cpap, and that the importance of reassessment as your patients evolve. One of the things that I had learned early on in my own career is that when the patient changes, particularly when they decline, if you don't have an impulse thing to do next to recheck the physical exam, recheck the vital signs, and get a better idea of what to act on next. And I think that that's pretty sound information that I carry with me through even my current day practice. The importance of continuous end-tidal CO2. You can see that with this patient, the intubation attempts led to a higher end-tidal CO2. But in addition, that even if the patient was on, a neb mask or Cpap, you can follow those continuous end-tidal CO2s to determine if the patient is fatiguing out. If you see the end-tidal CO2 rising, that should be in conjunction with their mental status as well, or give you an earlier idea that this is going to fail and that you need to move towards a more aggressive ventilation treatment plan. And then the induction agents that were used, I think it was very clear that the crews that used ketamine had used it specifically for the benefit of bronchodilation. And then evolution of airway management, especially after intubation was unsuccessful due to difficulties with paralytics. And then where we can improve, significant pneumothorax should be managed first. So once you determine that the patient's short breath, especially in this setting where the patient was reportedly unresponsive before being RSI'd, is that you really want to manage that pneumothorax prior to initiating or instituting positive pressure ventilation through intubation. And additionally, that this patient can progress rather quickly to potentially even cardiac arrest. And then I think that the dosing for this patient on the succinylcholine was appropriate for her weight. So why was the succinylcholine not working? So troubleshooting what's going on. Is the IV patent? Is there a blood pressure cuff up? Kind of looking at why repeating the exact same thing would lead to the same outcome. So trying to improve the processes that led to it not being effective the first time. And then this patient received only Versed after intubation. So remembering that pain control, fentanyl is the optimization first to manage post-intubation sedation with a close, if not slightly concurrent dose of benzos, which would be Versed. And then lastly, documentation was indicated that the decompression was successful, but I think it'd be really important, especially in these settings where the patient arrives to the hospital and that they aren't sure if the decompression was actually successful. So to document what specifically improved, is their vital signs improved? Was bagging them improved? Was there a wish of, or swish, or whatever word you want to use, of air that was that escaped after decompression occurred? Those would be things that or improvement in breath sounds. So all of these would be things that we want to document to suggest that this was successful, especially in the event that the patient declines further upon hospital arrival, and we can address why we thought that this patient improved. And another reason why we check, breath sounds with after intubation to confirm that the breath sounds were present prior to moving them or prior to transport. So in the emergency room for this patient, she was immediately assessed by the doctor. No left-sided lung sounds were noted. They grabbed an ultrasound and did a point-of-care lung slide ultrasound, which they saw no sliding of the lungs, suggestive of this patient had a significant pneumothorax still. A 14 French chest tube was placed with good breath sounds oscillated following the chest tube placement and a rush of air. The IG-L was removed and a trial of non-rebreather mask was attempted to see if the patient definitively needed to be intubated. Despite the fact that she had her pneumothorax decompressed and she was being ventilated, her mental status did not improve greatly. So the decision was made to intubate her after noting that she has a DNR but was okay with the trial of intubation. And then she was intubated using video laryngoscopy and succinylcholine and etomidate on the first pass. So would suggest that there was something wrong with the succinylcholine. One of the things that Dr. Whitwer had mentioned in the feedback to the crews is that, and you, Dr. Whitwer, feel free to explain further, but I believe that the succinylcholine may not be pharmacologically active, and that opening another bottle might be advantageous to ensure that it's not the succinylcholine that's the issue, the vial that you had previously. Is that correct?
Yes, they carry because the succinylcholine is pre-mixed. They carry it in their coolers, and anything can happen during this kind of warm weather. So the cooler may have failed for a while. You may not have been plugged in adequately. They may have taken it out of the rig, and if they thought they were going to use it for on another patient and then put it back, we don't know. I don't even know what the expiration date on it. So whenever something doesn't work, and you drew up the right amount, throw it away and take another one, or switch to rocuronium.
Yeah, a good rule of thumb. In the emergency room, this patient received the rounding out for reactive airway management with steroids. She was to the hospital, to the ICU. She was extubated shortly after her admission, in that she actually had an apical pigtail catheter placed a month earlier that was actually not plugged, not displaced, and decompressing her apical pneumothorax. So it was probably, in this patient's case, a bleb that spontaneously ruptured, leading to a pneumothorax in a different location for this patient. Her axillary chest tube that was placed in the emergency room was removed. She had the apical pigtail catheter left in place, and she probably at this point is discharged.
Yep.
So we've talked about pneumothoraxes and tension pneumothoraxes, I believe, within the last 6 months. So I didn't think that it was prudent to go into great detail or depth with this again. But I think what is important is to talk about how these pneumothoraxes can progress to tension pneumothoraxes, and potentially how quickly that is. So what I did do is I looked at a couple references in regarding how do you determine if a patient has a tension pneumothorax and when you should act. I think in this particular case, this patient's vital signs were in extremis. She wasn't necessarily hypotensive, but from what I could gather, we really aren't always seeing hypotension, from tension affecting the patient's cardiac function as we may have been taught originally. So from what I was gathering in the data is that if you decompress a patient and their vital signs improve, they likely had a tension physiology that was improved with decompression, and that these patients not intubated will likely go into respiratory arrest before they go into cardiac arrest. But once intubated, they do no longer have the means to compensate. They can't breathe faster. They can't increase their tidal volume. They can't decrease their tidal volume. So they're really dependent on your ventilation. So when we add positive pressure ventilation, we almost ensure that they're likely to not compensate and lead to cardiac arrest or hemodynamic pulmonary collapse. So as the positive pressure or the basically the positive pressure within the lung increases, they with the fact that they're either intubated or receiving BiPAP or Cpap, they can progress to tension pretty quickly. In that we really, once we're in the situation where we think that they are already decompensating, again, we really want to avoid going to managing their airway. This is going to be probably in these situations, if the patient actually respiratory arrests, we're going to bag them and go straight to decompressing them. We're not doing any advanced airway maneuvers. And in this particular case, they attempted a total of 3 times with an eye gel placed on the 3rd time. But sometimes it doesn't matter if you've got the intubation on the first pass. You potentially have delayed in those minutes of just placing an ET tube the first pass that could lead to this patient arresting, which can be difficult to get them back from. So, ideally, we identify this situation quickly, immediately address it, BLS their airway, manage their pneumothorax, and then address their airway after we've managed their pneumothorax. Any other thoughts about that?
Yeah, I just want to reiterate that the deadly thing for patients with a pneumothorax is to create a tension pneumothorax, and any positive pressure ventilation can do that. And so you mentioned CPAP and intubation, but don't forget a BVM is positive pressure, and just a simple BVM. I mean, basically, tension pneumothorax. The number 1 cause of tension pneumothorax in the United States is iatrogenic. In other words, it's doctors, EMTs, etc., because we do positive pressure breathing. Your lung is normally a low pressure system. It doesn't have any pressure in those airways, or about 5 millimeters maximum with the best inspiration you can do. When you do positive pressure, you're getting into 20, 25, and you just, cause that pneumothorax. We see pneumothorax and tension pneumothorax all the time with, especially in the old days, with bad CPR, where we broke ribs and little old people would get tension pneumothorax, and of course that's the end of them. Then they don't survive that unless you decompress them very quickly. So the answer, and doctors have the tendency also to go for the airway, but in this case, you have to keep a high index of suspicion. The first, and I reviewed this chart too because it was brought to my attention through a different mechanism, and the initial evaluation was excellent. There was no question, but you had to keep a high index of suspicion, and they did for tension pneumothorax, and they did reevaluate the patient. And then once they said, yeah, it's probably a pneumothorax. I mean, this woman has a history of recurring pneumothoraxes. So, I mean, what else can it be at a certain point? If it looks like a duck and walks like a duck, they'll end of that story. So but address the pneumothorax, which takes a couple of seconds, and then go ahead and then do your airway.
Absolutely, and I think in this particular setting, since the patient was being bagged through an eye gel, that it's imperative that whoever's ventilating mentions, or whoever is in charge of the scene asks the ventilator, is bagging the patient better, easier after decompression, because you really have a great idea of what if that attempt was successful.
Exactly.
So Clark County protocols for Cpap, I think we're pretty well. I won't make any assumptions. Indications: heart failure, pulmonary edema, non-cardiogenic pulmonary edema, any type of respiratory insufficiency or reactive airway disease requiring it. Also submersion that leads to hypoxia or shortness of breath, and then can be used in peds. But specifically contraindications, which are absolute, would be respiratory arrest, agonal respirations, unconscious, pneumothorax, or facial anomalies, or facial trauma, but specifically these are contraindicated either one, because it can progress that pneumothorax to a tension pneumothorax, or two, if the patient can't protect their airway, they can't either let you know they're going to vomit, or they vomit and they aspirate. So those are the major things. And then the facial anomalies would be, you're thinking about, you just can't get a good seal, and the same with the facial trauma. So to give you not just a bunch of indications, but contraindications, but reasons for why they are there. All right, so second case is of an 11-year-old male. Dispatch information is that this patient is unresponsive. PPE was appropriate and maximum. The patient was found to be unresponsive. I believe law enforcement was on scene already when our EMS colleagues arrived. The patient's airway is open, but he's not protecting. He looks poor or toxic. He's gray in color. He does have a pulse. There's no active bleeding. His initial vital signs early on into the case is that heart rate of 128, blood pressure of 145/96, bagging ventilation of 12, GCS of 3, and a pulse ox of 55%. Past medical history for this child is that he has a history of muscular dystrophy, and the parents were giving him breathing treatment when his stats started to drop. So that was subsequently followed with apnea, and that the parents started CPR and bag valve mask ventilation, which was continued by law enforcement until EMS arrival. So 5 minutes into the scene, IV was placed and iGel was attempted and placed on the second attempt. Defib pads were placed. Blood glucose documented as normal, and suction was initiated at 9 minutes for probably secretions. It wasn't clear the suction until later when he did vomit. 10 minutes into the scene, the patient had a pulse ox of 93% and tidal of 9, and then transport was initiated at 13 minutes. After transport, the decision was made to RSI this patient. He received 50 milligrams of ketamine and 48 milligrams of succinylcholine. Intubation was unsuccessful. Secondary unsuccessful, I believe it was difficulty with visualizing the anatomy, and that he also developed hypoxia. So after the first attempt, iGel was placed. Serial vital signs were obtained, notably just that his SATs have remained in the high 90s. His end tidal did increase to 69, and those vital signs continue to show improvement after ventilation with end tidal CO2 of 51. He vomited en route through the iGel, which was suctioned through, and then he arrived to, I believe, Legacy Salmon Creek at 42 minutes. So where I think we excelled is that this patient had a language barrier by his family, and that EMS was able to navigate through the language barrier. And I'm not sure if there was any English speaking on scene, or if this was all through motions and best attempts. But either way, excellent BLS airway management with suctioning and bagging, optimizing O2 sats prior to RSI instead of going straight to intubating the patient, trying to get his sats up to improve the odds that he has some O2 reservoir to tolerate any delay in intubation or difficulties. And then once intubation was unsuccessful, rapid progression to iGel placement and confirmation that you're able to bag him through the iGel. Where we can improve here is that succinylcholine is contraindicated in patients with muscular dystrophy, which I'll talk about later. This was reviewed by Dr. Mocht, and I believe the positioning and apneic oxygenation for RSI wasn't documented. His point was that reminder that having the patient more upright, approximately 30 degrees with apneic oxygenation, can help maintain SpO2s during intubation. So in the emergency room, he was finally intubated after the third attempt using video laryngoscopy. He got transferred to Dornbecker for suspected seizure and aspiration pneumonia. They trialed extubation on hospital day 9. He was re-intubated on hospital day 10. due to respiratory failure, in that the diagnosis, I believe this kid was back in May, so I don't have the final hospital course, but the current diagnosis at the time was acute on chronic respiratory failure.
Dr. Gavois, what would in the hospital that I'm assuming they intubated him using rocuronium?
Yeah, well, I can't pull up this case because he's never had a Peace Health encounter, so I don't exactly used unless Dr. Mock is on. But yeah, I'm not sure what agents were used. I try to include that when I think it's meant for our case reviews.
Right.
So a brief discussion of the condition of muscular dystrophy. It's a genetic disease affecting muscle composition. There's greater than 30 different types of muscular dystrophy, in that all of them share that they lead to progressive weakness and degeneration of skeletal muscles that can present themselves early in life, midlife, and have various degrees of weakness associated with it. There's a list of the more common types of muscular dystrophy. Duchenne's is the most common type that we will likely see, and it has a predominance in the male gender, although there are female patients that suffer from Duchenne's muscular dystrophy. So I believe a lot of us get emails from me about why we shouldn't use succinylcholine in certain conditions. So instead of just saying it, I hope to explain it a little bit better. So succinylcholine is a depolarizing neuromuscular blocking agent. And this picture over here on the right is to represent an action potential from a acetylcholine receptor down in the motor end plate in the synapse. So when succinylcholine is used, it acts as an agonist on the acetylcholine receptors. It's not, since succinylcholine is not acetylcholine, it's not broken down by the method that usually occurs, which is acetylcholinesterase. So its binding to acetylcholine receptors are prolonged, as opposed to the non-depolarizing muscle relaxants or paralytics, which act as a competitive antagonist at the acetylcholine receptors. They bind, so non-depolarizing bind at the acetylcholine receptors, but they do not actually create an action potential to occur. So going back to our drug here, succinylcholine, once it binds, it acts as an agonist, and it produces, as you can see in this image here, once it binds, it produces an electrolyte flux, where sodium comes in and two potassium come out. And in a normal condition, anywhere from 0.5 to 1 milliequivalent of potassium in the concentration in the blood may occur when succinylcholine is used. In normal functioning kidneys, that usually is not an issue. But where we run into issues is when the kidneys aren't working properly, or that there might be increased amount of acetylcholine channels, such as in muscular dystrophy, but also in our abnormal muscles, such as rhabdo or muscle injury. So we don't want to use succinylcholine in patients that are at risk for hyperkalemia in either kidney impairment or increased action of acetylcholine receptors, such as in muscular dystrophy, or that there's damage to the muscle that could lead to uncontrolled potassium release into the systemic blood volume. So really, really, really need to pay attention to when we do not use succinylcholine, because none of us want to create a condition that makes a patient arrest and potentially, if not identified quickly, or even when identified quickly, could still lead to not being able to get ROSC back on them. So in summary, don't give succinylcholine to patients with muscular dystrophy. Don't give it to Renal failure patients, either known or suspected, don't give it to individuals that have muscle injury from an acute issue, such as long downtime on the ground or crush injuries. So this is just our protocol locally, where we talk about the fact that succinylcholine is a depolarizing agent that should not be given to anybody with burns or crush injuries, neuromuscular disease, or suspected hyperkalemia, or they're already sensitive to the drug. Any questions? All right. All right, and then case 3 is kind of a potpourri of cases. So late June, we all experienced particular temperature anomaly. For those that had air conditioning, they had less of an effect. For those who didn't, such as myself, it was more profound. So first case, 59-year-old male that EMS is called to go to a psychiatric possible abnormal behavior issue at a park. PPE usage was appropriate, and they find this patient awake. His airway is open, he's protecting it, his pulse is present, and there is no active bleeding. 5 minutes after patient contact, they were able to get a set of vital signs notable for tachycardia at rate of 151 and a GCS of 9. From my understanding from the documentation initially is that the patient was awake, confused, and acting erratically, so maybe a GCS of 14, and then after arrival on scene, he had a profound decrease in his mental status. Blood glucose checked and documented as normal, and the past medical history available for this patient is that he has a history of schizophrenia and anxiety. This particular day, it was 116 degrees. Police on scene stating that the patient's altered. Additional information is that he's speaking to people not present. He ran face first into a tree, and he's swinging at imaginary assailants. The patient himself, prior to his mental status change, had no complaints. So 3 minutes after patient contact, an IV is established, and he gets 300 mLs of IV fluids. His external temperature is 41.6. And then he has the vital signs that we talked about, and that was upon patient transport. Vital signs are repeated, and he's still tachycardic, but otherwise not significantly changed, and he arrives to the hospital 18 minutes after patient contact. It's documented that cooling measures were started, and that they also document that they attempted to get an EKG, but due to profound diaphoresis, they were unable to get an EKG on this patient, in that they also documented that he vomited several times en route to the hospital. So in review of our pre-hospital information, they did serial vital signs, even for such a short scene time and short amount of time with the patient. IV was established. They document cooling was initiated, blood glucose was checked, and they documented the barriers of initiating treatment or checking particular things that we would like to check on patients of this particular type. I think that we can do a little bit either more documentation or improve is that if he ran face first into a tree and he's altered, I wonder if we should be considering spinal precautions. Once he started vomiting, consideration for trying to get him an antiemetic, even with the short duration of the transport, and then really doing a better job of documenting specifics to cooling measures. And which is kind of a theme in all of the cases, is that if it's documented as cooling was initiated, the specifics of what was done was never discussed. So in the emergency room, the patient past medical history includes not just schizoaffective disorder, but also methamphetamine abuse. His rectal temp was 106.5. He was Auricide using etomidate and rocuronium. So another case of making sure that we don't lead to worsening hyperkalemia with using succinylcholine. And he was intubated because he had not intractable vomiting, continuous vomiting. So he was determined to have hypernatremia, so an elevated sodium. His creatinine was elevated. He was hyperkalemic. His urine drug screen was positive for meth. He had some rhabdo with an elevated CK. He also had an elevated troponin, and they had also worked him up for a possible stroke. And they noted that although this was not contributing to his presentation, that he had a significant stenosis of one of the blood vessels in his brain. And the cooling protocol was initiated. Cooling protocol that was documented for this patient was a cooling blanket, misting fans, ice packs to the groin. He was admitted to the hospital after intubation to the ICU. Cooling protocol was continued, and he received IV fluids to fluid resuscitate him. He got extubated on hospital day 2. His kidney function, his sodium, and his confusion resolved. He was offered to being seen by psychiatry, but he declined, and he was discharged on hospital day 6. Next case is a 92-year-old male that they were called for heat exposure, not alert. PPE usage is normal or appropriate. The patient was awake but confused. He had an open airway that he was protecting. His pulse was present, but it was noted that he was pretty hot to touch. Vital signs notable for tachycardia at 110. Otherwise, his GCS was 12. Past medical history is just hypertension, hyperlipidemia, that they likely was not contributing to his presentation. And a little backstory is that this patient lives independently with a mild amount of dementia. It sounds like his adult children are involved in his care. In that this day also was reported to be at least 110 degrees or higher. And they found this patient in the backyard with his pants lying next to him, found by his son. And the information that EMS had was that they don't know when his last known normal was. They document a temp of 103. The vital signs that I mentioned earlier, 4 lead was documented, but not in the chart. And an IV was established, and he received 500 mLs of IV fluids. His transport was initiated at 15 minutes, and he arrived to the hospital at 27 minutes. And I put the narrative in this because it doesn't mention anything about cooling. As I mentioned before, either in the narrative or in the procedures. So temp was assessed, IV was established. We're great. Let me just double check. I don't think a blood glucose was checked on this patient. And where we can improve is ideally with a 92-year-old confused, altered patient who's in this condition, getting a 12 lead would be ideal, but more importantly, checking a blood glucose and obtaining cooling measures or treating with cooling measures and documenting that as such. I believe in this next, in this next slide, the hospital documents that EMS had started cooling, but we don't document it in our chart at all. So I believe from what I could see in the emergency room documentation is that EMS had brought this patient in as a possible sepsis. The patient was cooled with ice packs to the groin by EMS. Temporal reading, so they did not do a rectal or core temp, was 104.2. His workup was notable for an elevated sodium. He also was in renal failure, and all imaging that was obtained, including head and spinal imaging, was unremarkable. He did get 1 dose of antibiotics, although the leading diagnosis was heat stroke. So the patient was cooled with the same protocol as mentioned previously. So cooling blankets, evaporative fan, groin ice packs, and IV fluids. And his confusion and his kidney function resolved during his hospital admission, and he was discharged on hospital day 5. believed to a sniff. Last case is a 79-year-old male who was on a motorcycle, or at least holding it. EMS was dispatched to a heat exposure altered mental status patient. PPE usage was appropriate. He's awake, his airway's open, his pulse is present, but they note that he's dry and hot. Vital signs are only notable for hypotension at 88/50. And although the patient answers questions appropriately, EMS does document that he seemed confused. Temp is 100.6 externally. Only history that is reported is hypertension. In the story they received is that this patient was at the Costco gas pumps on his motorcycle waiting for approximately 2 hours for fuel. Not certain if any of you guys are wondering why it took 2 hours. I don't know if it was just a big delay or if there were some logistical problems, but they noted that the staff at Costco noted that he seemed confused. He couldn't find his keys. And when family was contacted regarding his presentation, they noted that he was seen in the clinic earlier and told that he was in renal failure and that he needed to go to the hospital. And that day it was at least 110 degrees outside. So vital signs, as I mentioned earlier, he got an IV. Transport was started at 15 minutes and he received 1 liter of IV fluids. He got a 4-lead EKG documented, but there is no tracing in the chart to review. Repeat vital signs show that he's still hypotensive, and then he arrives to the hospital at 25 minutes after patient contact. And somebody is doing something active in the background, so if they could either mute themselves if they continue to be active or whatnot. So I include the narrative here again because we don't document any type of cooling considerations, nor in the protocol or in the procedures either. So IV access, they got a 16 gauge, they did serial vital signs, no 12 lead for a patient who is reported in renal failure and hypotensive, no blood glucose, and no cooling treatment documentation. So in the emergency room, his rectal temp was 99.9. Cooling was initiated. His creatinine was 4.8, but his potassium was normal. And they thought that his renal failure was secondary to both heat exertion, dehydration, and hypovolemia. And that he was actually seen in orthopedic clinic earlier that day, noted to have a blood pressure of 75 systolic, and through screening labs noted to be in renal failure. He was admitted to the hospital. He received IV fluids. They kept all of his antihypertensives to not contribute to his hypotension any further, and he was discharged on hospital day 5.
Couple of comments. I saw in your I saw in the narrative that they documented a CBG, but I didn't see that they documented the CBG by a number any place.
Is it in this one?
Yeah. Go
Yeah.
right up, right down there. It says CBG right at the bottom.
Yeah. I can double check, but I'm certain it was not in the vital signs.
And then I'm really curious, which orthopedic clinic allowed a guy with a blood pressure of an old guy with a blood pressure of under 80 to leave?
Maybe he was hostile.
Yeah, agitated dementia.
Yeah.
I know how that is at age 79.
Yeah. So it's a little bit after the fact, but it's all right. I think that we can still learn from these cases. So we're talking about that unprecedented heat wave we had in late June, leading to these various forms of heat emergencies. So heat emergencies is whenever the body's ability to, let me just see what that is. Yes, I see that, Chief Ford, and I will talk about that too. So it's when the body's thermoregulatory capacities are overwhelmed and it's leading to the lack of thermoregulation. So baseline temperature of any given patient should be 36.5 to 37.5, and that we have mechanisms to address variations from 35 to 41 degrees Celsius. Those are vasodilation, specifically to the face, the palms, the feet, increase sweat production, decrease metabolism to decrease the amount of heat production, and then behavioral modifications, which would look like taking clothing off, turning the air conditioning on, turning a fan on, loosening any additional clothing that you do have, or shedding layers, and then seeking shelter, if I hadn't mentioned that earlier. Um, the heat exchange occurs through evaporative, convective, and conductive and radiative losses. As temperature and humidity increases, our conductive and radiative losses are less efficient, and it becomes more important for our evaporative losses to be the primary function to decrease our heat. So who's at risk of a heat illness? So anytime that we have high temperatures and or high humidity, heat wave, interestingly, a heat wave is considered anytime there's 3 consecutive days or more of 90 degrees of Fahrenheit. Age extremes, so those are going to be both your pediatrics and your older individuals. And then the pediatrics is due to increased body surface area, decreased blood volume, immature thermoregulatory processes, and slower acclimation, as well as a higher set point. In our older population is going to be somewhat related to like hypothalamus, pituitary function, but also the medications that they're taking can impede their ability to thermoregulate, as well as like endocrine dysfunction, like thyroid problems. Obesity, hydration status, alcohol consumption, drug use, specifically sympathomimetics, concurrent infections, or any other comorbid medical conditions. One of the things that you can also, so sympathomimetics, like in that case of the 50-something-year-old who's schizophrenic and also has a meth history and is meth positive, that doesn't help his situation. So I'm going to talk briefly about the 3 different types of heat emergencies. I'm going to start from the bottom. This is an image that comes from the CDC, and I thought it probably is decent to kind of talk about. I think the temperature cutoff is a little bit it varies depending on what your resource is. So don't necessarily get hung up on the 103 up there. But so heat cramps, they're going to be anytime there's involuntary spasmodic contractions of a large muscle group. It can also be associated with kind of GI and like generalized complaints such as nausea, vomiting, fatigue, and weakness. In that, so I'm going to just talk about the left side here. Heat exhaustion is going to be whenever the temperature is, the patient's body temperature is elevated, but it's usually not significant, and depending on the resource, either not greater than 103 or not greater than 105. And they can have a plethora of complaints that can be anywhere from vomiting, dizziness, lightheadedness, irritable, headache, thirsty, weakness, and and then lastly is going to be your heat stroke. And so those are going to be conditions where the temperature is higher than the rest of these 2. And it's usually leads to CNS derangement. So they might have a seizure, they might be confused, delirious, they might have problems walking. And then in this review, there's also another type of heat stroke that they spend a lot of time in differentiating from the common word for the typical heat stroke. So exertional heat stroke, or EHS, and that's when a patient is hyperthermic greater than 40.5 degrees Celsius and it's occurring in the setting of physical activity, and they have to have CNS disturbances. So again, the altered mental status, gait instability, seizures. And it doesn't necessarily mean the difference between exertional heat stroke and heat stroke is that it's usually, it doesn't have to do with thermoregulation problems like our young and our old in that previous traditional heat stroke description. And it doesn't necessarily have to be hot outside. These are patients that are physically exerting themselves and they can't dissipate their heat. They may be diaphoretic on the skin exam. They might have a external temperature that is normal and that the ambient temperature to us feels normal, but you take a rectal temp on these patients and they're 105 or 106. So in our exertional heat stroke, and you can think of these are like marathon runners or like military training or football training, like college football level, kind of really working very hard to train and not able to dissipate that heat. So in these conditions, we really want to identify it pretty quickly, have a high index of suspicion for it. And if we find a patient in this particular instance, the gold standard is to aggressively cool them and preferably through cold water immersion within 30 minutes of identifying this condition, which can be problematic. One, because we don't have any resources that allows us to do that in our pre-hospital setting. So you do the best we can and try to notify the hospital appropriately so that they can mobilize getting this patient cooled quickly. So if cold water immersion is not available in this particular image is that TARP assisted cool water immersion. The other options would be to place ice packs near arteries. So that would be like groin, axilla, neck, although in itself, it's not horribly effective to get the patient's temperature cooled down quickly. Cold IV fluids, even if it's 36 degrees cold Fahrenheit cold, it's going to decrease the temperature of a patient, a core temperature of a patient by 1.8 degrees Fahrenheit after 30 minutes. Evaporative cooling might be an option. And then I was reading, this is more utilized in the military setting, is ice sheets. So sheets that are drenched in water, placed in a cooler with ice, and then all the skin has to be exposed. The cool ice sheet is placed on them, evaporative if possible. So setting the fans in our environment, and when the sheet becomes warm, replacing it with another sheet that's in that cooler to improve the temperature decrease. So if cold water immersion is not available, really we need to do more than just one combination of the bullet points below to try to improve our chances of decreasing their hyperthermia in a expeditious manner. So back to heat cramp, heat exhaustion, and heat stroke. Stop the activity, move them to a cooler environment. It's going to be supportive for everything outside of heat stroke. So if they have heat cramps, you can elevate their legs, massage their legs, or have them massage their own legs. In that, what I was reading is oral and IV rehydration is equivalent, but obviously in a lot of those patients, they might be nauseous or vomiting. So trying to eliminate aspiration might be helpful. And that lukewarm water spray over the skin with forced air conduction could be helpful. I can tell you without air conditioning myself, cool water misting to the face was very appreciated during my suffering. Anyways, and then for heat stroke, it's going to try to be more aggressive in cooling them down, removing any excess clothing, ice packs to where there's arterial flow, and cold IV fluids, cooling the temperature of the environment that they're in. And then the data says that there's no role for antipyretics or muscle relaxers when these patients are either febrile or having uncontrolled muscle spasms. And then for our protocols, it's a reminder that it doesn't have to be heat. It could be also from toxidromes such as sympathomimetics and anticholinergics. and that our protocol for heat syndrome, which would be helpful to do, but also to document, is to document that you are moving them to a cooler environment, removing excess clothing, trying cool compresses, their forehead, their necks, oral fluids if possible, starting IV fluids, no more than 500 cc's, and transporting them for our heat cramps and heat exhaustion, and then heat stroke, similar to the above treatment, but also using wet sheets and evaporative airflow and more aggressive treatment in this realm. We do document, or we do talk about the indication for Versed if they're having a seizure, but there's also mention for shivering, and then addressing any tachydysrhythmias or altered mental status. Any questions? I am assuming not, so I'll move on to the next and the last. Thank you guys for your time. We're just a little over an hour. So this is a case that occurred yesterday, and I think that it's timely given the difficulties that we have either already experienced or will likely experience in the near future. So EMS is called for an agitated male of an unknown age. So in the chart, this patient's awake. His airway's open. He has no visible signs of active bleeding, but no physical contact was made with this patient. This was all based off of visual assessment from afar. This patient has a history of alcohol abuse, low sodium, and cirrhosis, likely from his alcohol abuse. In that the story that they're getting is that this patient has been drinking gin since early morning, according to his sister, who's also the patient's power of attorney, and that the patient keeps on coming in and out of the trailer, yelling accusations, shaking his fists, stating that he's not going to go to the hospital. His sister says that he is yelling at himself and yelling at having hallucinations of children in his backyard, which are not there. She would like him to come to the hospital because he's presented similarly in the past, and that it bought him an ICU admission. And then this is the narrative minus what was in the previous slide. I think that this is a great example of documenting appropriately the information. I blacked out any people's names, but I can read it out to you since it's so small. The male subject does not wish for any treatment or transport and was presenting in an agitated manner. He periodically would come out of the hospital and yell at EMS crew and the family, telling EMS to leave. Sister states that she took his keys away from him so he would not leave the house because he would try to drive in the state. And the sister says that he previously crashed his car while he was in a similar state of alcohol intoxication. And due to his agitation, unpredictable actions, and unknowing if male had any weapons inside the house, the crews withdrew from the scene to a safer distance. The crews requested law enforcement for crew safety, and that adult mobile crisis was also requested and had responded. AMR supervisor was contacted and updated regarding the presenting issues with this patient, and that online medical control was contacted for further instruction on how to proceed. Online medical control recommended that the patient not be left at scene and to be transported, and they also recommended that that physical restraints and sedation should be utilized as necessary to facilitate transport. Adult mobile crisis responded, and they spoke with the patient's sister and determined that he was intoxicated and was hallucinating. The patient was not interested in accepting any medical, mental health, or alcohol treatment at that time. Law enforcement arrives and they stage nearby. Adult mobile crisis team, sister, and EMS and law enforcement meet together and determine, since no crime has been committed, patient was not deemed suicidal nor homicidal, that EMS had no legal indication to restrain and transport the male without his consent. And they talk a little bit about the legislation but they say that law enforcement is unable to place male on a mental health hold, and that law enforcement has a duty to leave scene if male becomes hostile. They document that no contact by EMS was made with this patient or this male subject. I guess I should be careful about using the word patient, and that no assessments were able to be completed. They're unable to provide refusal paperwork or signature to this male party, in that the sister was informed that if the male's condition changes or if he decides he wants help at a later time, to call 911 back, and EMS would be happy to voluntarily transport male for further evaluation and treatment. Sister advised she removed all the male's car keys and that she could find, and that the neighbor were all keeping watch in case this male escalated or became incapacitated, and then they cleared the scene. So really a very thorough documentation of what needs to be a thorough assessment and care. This particular checklist comes from I believe it was the state of I think it was the state of Washington's consideration for what to identify as an unsecure scene. So any signs of impending violence, which I won't read out to you guys, you can read it, and for those that are listening, you can watch the video later. And then what can be done to de-escalate that situation.
I think this actually comes from Snohomish County. I don't think the state has adopted a full-fledged thing yet.
Yeah, that might be.
But then it's a compilation of there's the agitation score that Multnomah County has a whole agitation score and risk kind of scoring thing, and it takes a lot of effort to do it. It's and it's graded from 1 to 6 and everything. So, but I mean, these are the salient points, and I think learning another scale is not really necessary here. I think I like the mitigation de-escalation section, but.
And then to reiterate what our updated behavioral emergency protocol is. So I'm going to briefly talk about the left, but I'm going to really focus on the management of aggressive violent patients. So making sure you're seen safe, approaching a patient in a way that doesn't escalate them further, and if the patient's agitated, following the agitation protocol, trying to get as much of the history, physical exam as possible, and treating any medical conditions per our protocols. And then if the patient is eligible for transport to an alternative site, what those options are and what the steps needed to be documented and followed through. Remembering that there's adult mobile crisis and there's also the corresponder program. And then I'm going to focus more on this here. So the first one, specific precautions, kind of giving you guys a clue or a heads up on, is this patient like a medical condition that's making them act delirious or encephalopathic, such as waxing and waning level of consciousness? Are there vital signs abnormal? Is there evidence of like a stimulant such as dilated or pinpoint pupils, or I guess you can say stimulant, or a depressant? In that these usually don't occur at over the age of 30 for all of a sudden erratic behavior due to a psychiatric condition. And then as for psychiatric conditions that signs and symptoms are mood and thought disorders and how they present. So moving down to the box below, the management of aggressive violent patients. We've shared this, I believe, not just at the level. I believe that you probably have seen it in last month's or this month's protocol update, but another reiteration trying to make sure that we are all aware of what the current guidance is. So law enforcement will intervene only when an individual poses a threat to others or themselves, or has brought harm to others, or has committed a criminal offense. So only if they are a threat to others or themselves, brought harm to others, or criminal offense. They will focus on least force necessary to secure the situation, and they may disengage or not arrive to the scene. You need to treat these encounters with your safety as paramount, and recognizing that you may not have law enforcement coming to help with your situation. So scene safety, as we know with our general scene size up, is paramount, and we can't help anybody if we're injured. Using all necessary means to de-escalate the situation. And if at any time the patient becomes aggressive, violent, unpredictable, and you believe your safety or your partner's safety is at risk, or your colleague's safety is at risk, you need to remove yourself. Contact law enforcement via CRESA and terminate the call. So again, your safety is paramount. You need to make sure that you don't put yourself in a situation to get injured, especially knowing that you may not have the ability to have law enforcement to assist you. One of the things that we talked about in one of our meetings that I will mention here, and I'll see if we still are in agreement, is that these are not our typical against medical advice refusals. These are a whole new kind of category, in the sense that we would in previous days with the support of law enforcement, we would transport these patients because the concern is that they didn't have the capacity to refuse. So we had talked about not contacting online medical control to approve against medical advice refusal, as they will not see this as an against medical advice refusal. They will see this as a patient that needs to be transported by any means necessary to get them to the hospital. Is that currently the recommendations of the MPD's office, that online medical control for these situations should not be initiated unless there's extenuating circumstances or you need assistance in decision making?
Yeah, that's going to have to be formatted so it's more easily understood, whether we put that into a flow sheet or such that. But this will be basically an exception to. Well, it won't be an exception. This will be a protocoled non-patient or non-encounter, non-refusal required. So this will not be the classic against medical advice kind of thing. Now, sometimes medical control might be reasonable to be contacted if there was a suggestion of thinking of something else, but I think online medical control around the state has already shown that it's kind of confused about what's happening with they don't know what all the agencies are doing. They don't know what all the police. I mean, the problem is law enforcement is interpreting these things at their own level now, at their own agency level, by their partly by their attorneys, partly because of their anxiety about what the other parts of the law say, because there's another law that they're really worried about that defines penalties for police. Any rate, we will have to protocol that so that medical control contact will not be necessary in this case. If you go through all the process, then you essentially have gone through medical control, our protocols, and we will not require a medical control consult.
And to echo Dr. Whitmer, if you're calling to confirm that this patient will not be transported, that would not fall into the category of online medical control. But if you have a question, a request, need for their assistance in decision making, that would be appropriate as well.
We're going to have several because I've done this for a few years, and there's a lag time between what the physicians understand, the medical control physicians understand at their end, and a lag time between what our own personnel know, because we have a month and a quarter roughly for people to catch up on each PCEP and each presentation, and frankly, I'd say that probably at this point only a half to 2/3 of the EMS force in Clark County has seen and digested the PCEP 2 weeks ago, in which we presented the new changes in protocol. Now, there are now new changes going to be coming out in this, but there's a lag time between. I'm sure this crew that we talked about, that Dr. Gadbois talked about in this case, had not seen even this new iteration of the protocol, and so it's going to take this is a work in progress. It's going to take the Chief Milano sent a note saying, hey, can we add these checklists and things to our behavioral emergency protocol? Yes, that can be added. This is a work in progress, and we're trying to get a sort of simple flow sheet with things that you can click on to go to little helpful aids like this. But this is not over and done with yet, and I expect that we'll have a lot of issues over the next few months.
Absolutely. And for those that aren't aware, it's House Bill 1310. What was I going to say? We want to know about these cases. I believe right now we're asking for you guys to let your administrators know, and that'll hopefully funnel to us. But I believe that we'll also be pulling that, doing a report on these two, because we want to make sure that we're doing our best to support the community and these patients.
And we're working with the DCRs to try to set up, to try to expand their ability to respond. They already will respond to your request. As you can see in this case, this actually the case that Dr. Gadbois presented is actually sort of the way we expect it to go down, in which the DHR came out and made contact with the patient, or at least verbal contact with the patient, and with the sister and with the VPD, and everybody met and agreed that this is the way it would be. And the only problem with this one is that the crew then called medical control, who frankly was not aware of the medical control physician, was not aware of the change in the law, had not seen the updated material that Dr. Gadbois had presented last week, and so said, oh, well, you got to transport this patient. Well, that's not the way it works. So I mean, this is it takes a while for all this information to get out. And then we'll be developing things. Now, one of the things that Dr. Gadbois, unless I missed it, did not mention that we are encouraging you to do, especially if people are in a house or in a car, is that we're going to, just like we did with COVID, request them to come to you. In other words, to come out of the house, to get out of the car. You're not expected to put yourself at risk by going into the house if there's a potentially violent scene. Sometimes people will just come out. We've had a lot of behavioral health people before who would refuse to come out of their house, and then we would disengage. Now, that sometimes is necessary to do that. but documentation, and we are going to try to see if we can pull a report out of meds and a report out of ESO that would identify these patients, but so we can have a way of keeping them tracked. But I've asked AMR and all the other agencies to call these patients at this time MPD cases, just like cardiac arrest cases so bring them to the attention of your supervisors so they can send us the charts and we can start to compile the numbers of cases and then deal with our police and sheriff agencies to try to ameliorate, to adjust to this situation as much as we can. That, you know, it's only fair to note that the law enforcement doesn't like this either. They're anxious about it. Like I said, that this 1310 isn't it isn't that bad a bill as if you look at it all by itself. The problem is there's a companion bill, which I forget the number, that defines that goes into great detail in defining what levels and what types of restraint and force they can use, to include that it's against the law in the state of Washington now to use a chokehold or a neck hold, any neck restraint. So that's an automatic. And then the bill goes on to define penalties, which could include loss of somebody's badge, civil and criminal penalties, including money. So that's what's making them very anxious.
Understandably. That is all I have for everybody. If you guys have any questions, feel free to put it in the chat or to send it to our office or send it to me. And as always, if you have any questions or concerns, either in real time, ask me if I'm on shift, or send it to our office to address.
Okay, thanks, Dr. Gadbois.
Thank you. All right, I'm gonna head to work.
All right, have a good one.
Thank you.